चले तो Bismillahirrahmanirrahim. Thank you for joining us in this hypertension workshop, and we are hoping कि ये interactive होगा, and as people start coming in, they will continue to join us with different inputs. But हम जो है इसको right away शुरू करते हैं. थोड़ा सा बैकग्राउंड ये बता दूं मैं कि मैंने कुछ अपने ज़माने में हाइपरटेंशन क्लिनिक, जो रेजिस्टेंट हाइपरटेंशन क्लिनिक को चलाता था, एक हाइपरटेंशन ट्रीटिंग ग्रुप जिसमें नेफ्रोलॉजिस्ट, कार्डियोलॉजिस्ट, इंटर्निस्ट और जो हाइपरटेंशन के एक्सपर्ट थे और एंडोक्रिनोलॉजिस्ट रोटेट करते थे, वो रन किया है 2-3 साल. और वो एक्सपीरियंस के बेसिस पे मुझे ये लगता है कि हाइपरटेंशन शुड बी समथिंग दैट एक्चुअली शुड बी एवरीवन्स बिजनेस, और इसके अंदर everyone should be on the same page. वो क्योंकि ये and for the reasons we will see. तो आज के वर्कशॉप की जो ऑब्जेक्टिव्स हैं वो यही हैं कि टू हाईलाइट डायग्नोस्टिक थेरेप्यूटिक अप्रोच to managing primary secondary hypertension by using 20 case-based learning scenarios, and discussing the options and reviewing and all the guidelines from European Society of Hypertension 2023, European Cardiology Association Society 2024, and American College of Cardiology, American Heart Association 2025 guidelines. और फिर देन टू टेस्ट आवर लर्निंग ऑब्जेक्टिव्स आउटकम्स के वो फुलफिल हुए हैं थ्रू अ 20 आइटम पोस्ट टेस्ट quiz. So we will just start off right away with these quiz items, and try and take responses for whoever is present online. And so the first case is a 45-year-old lady who comes to outpatient family medicine clinic with recent onset of morning headaches, fatigue. She's postmenopausal, 3 pregnancies, the last of which was 12 years back. She had transient gestational hypertension but did not require treatment. Her current exam is remarkable for blood pressures of 148 by 92 millimeters mercury on an average of 3 readings, with an automated blood pressure device following a month of close observations. So the initial screening test that may best help in determining her cardiovascular risk is, any thoughts? A, B, C, D, E?
It could be EKG and ECG
Okay, so
to look for left ventricular hypertrophy.
so the to cardiovascular risk को best करने के लिए it seems के is the fasting lipid profile. ठीक है. So वो ECG and echo वगैरह में तो hypertensive mediated end organ damage को detect करने के लिए वो अच्छी चीज़ है. बट कार्डियोवास्कुलर रिस्क के लिए जो कि विच इज पार्ट ऑफ द प्रिवेंट स्कोर जो आजकल यूज कर रहे हैं, एंड जिसमें 10 ईयर कार्डियक रिस्क मोर देन 7.5% या 30 ईयर कार्डियक रिस्क, जो हाई रिस्क होते हैं वो सारे वो कैलकुलेट होते हैं उससे, एंड वी विल गो थ्रू दैट. So, the lipid profile, inclusive of both the total and HDL cholesterols, is part of the score and prevent cardiovascular risk scores and progressively confers higher risk. Hyperhomocystinemia भी हो सकता है कुछ लोगों में, but cost effective नहीं है to screen for it. HbA1c जाहिर है screening test recommended है for diabetes by both the ESH and ACC. ECG, EKG will determine LVH as a manifestation of hypertension mediated organ damage, and is recommended by the Europeans, by all these societies, but is not included in the score risk calculator. Or 2D echo is recommended as an optional test by American College of Cardiology. Second question, let's just see this. 23-year-old male comes to medicine clinic, dyspnea, fatigue for 1 month, overweight with a blood pressure BMI of 32 kilograms per meter squared. Current exam is remarkable for BPs of 165 by 96 on an average of 3 readings in the office with an automated BP device, and the initial screening test that may help in determining his renal involvement risk best is?
It could be urinary albumin to creatinine ratio.
So you are saying urinary albumin to creatinine ratio. तो उसको जो है we can see. That is absolutely correct. And it's a good screening test for renal involvement, both in diabetics as well as non-diabetic, with or without uh, hypertension, and is associated with both renal and cerebrovascular worsen outcomes. क्रिएटिनिन तो मसल मास का मेजर है. यूरिन डिपस्टिक जो है उसमें प्रोटीन यूरिया will depend on the specific gravity and concentration of it. और वो भी hypertension mediated end organ damage का एक एस्पेक्ट हो सकता है, बट उतना स्पेसिफिक नहीं है. और यूरिन सेडिमेंट एग्जामिनेशन ज़ाहिर है उसके अपने कबात है इन टर्म्स ऑफ सस्पेक्टिंग जीएन और एटीएन or AKI or ultrasound kidneys for screening for chronic kidney disease. So moving to number three, a 55-year-old female comes to GP clinic with nocturia and occasional swelling of feet since the past 3 months. Her BMI is 34. Her current exam is remarkable for blood pressures of 145 by 95 on an average of 3 readings, 1 minute apart in the office with an automated BP device, and have been confirmed by mean ambulatory blood pressure readings over 140 by 90. And her urine exam and ultrasound kidneys are normal. The initial screening test that may best help in determining an endocrine cause is.
जी सर.
चले, तो इसमें ये सारे पॉसिबल हैं थोड़े बहुत. तो बेस्ट आंसर के लिए शुरू में बस वो आप इलेक्ट्रोलाइट्स ही कर ले. So you might see unprovoked hypokalemia and hyperaldosteronism in up to 40 to 50% cases. और वो क्योंकि अंडर डायग्नोज्ड है उसी को ही पहले देख लें. उसके अलावा of course, fasting diabetes, fasting blood glucose levels over 7 millimoles, या pre-diabetic states with associated metabolic syndrome, वो भी चीज़ें nice to screen for. Cortisol levels isolation में and less useful है for Cushing syndrome, और उसके लिए dexamethasone suppression test ज़्यादा बेहतर है. प्लाज्मा रेनिन टू एल्डो में बी अ नेक्स्ट स्टेप आफ्टर, जब एक दफ़ा आपने इलेक्ट्रोलाइट्स में अनप्रूव्ड हाइपोकैलेमिया देख लिया. और प्लाज्मा फ्री मेटानेफ्रिन अगर फियोक्राइमोसाइटोमा सस्पेक्ट कर रहे हैं इन द राइट क्लिनिकल सेटिंग. यहाँ पे कोई बहुत ज़्यादा कोई ऐसे उन्होंने फीचर्स टू सस्पेक्ट फियोक्रोमोसाइटोमा नहीं बताए. बट या ऑब्वियसली ऑल ऑफ देम कैन बी the right answers in the right setting. So, a 60-year-old male with type 2 diabetes is seen in cardiology with an abnormal clinical exam. His BMI is 27, blood pressure is 150 by 80 on an average of 3 readings. With an automated BP device, he has an S4 on cardiovascular exam, but no S3, and his peripheral pulses are normal. The initial screening ECG that may best help in determining left ventricular hypertrophy ECG finding is.
It could be sum of S in V1 and R and V5 over 35 millimeter.
Bilkul. So the sum of S in V1 and R in V5 being over 35 is the classical Sokolow-Leon criterion, or modified Cornell criterion में R in AVL should be more than 12 millimeters. यहाँ पे कुछ 9 बताई हुई थी. LAD जो है थोड़ा सा नॉन स्पेसिफिक है. LVH में भी हो सकता है, दूसरी चीज़ों में भी. और लेफ्ट बंडल ब्रांच ब्लॉक भी जो है कैन बी नॉन स्पेसिफिक. और टॉल आर वे V1 में तो वो RVH का निशानी है. बिल्कुल सही. Okay, a 30-year-old female gravida 1 para 0 is seen in nephrology after repeated blood pressures of over 160 by 100 in the 26th week of pregnancy. Her BMI is 24. Her blood pressure is 160 by 80 on an average of 3 readings. She has a normal cardiovascular exam and has ankle edema. The test that may help best in determining risk of preeclampsia is.
See.
Okay, so urine spot protein to creatinine ratio more than 300 milligrams per gram, absolutely right. And preeclampsia, of course, can occur after 20 weeks, up to 4 to 6 weeks postpartum, or criteria include systolic BP more than 140, diastolic more than 90 on two occasions, 4 hours apart. In previously normotensive patients, yeah, systolic, diastolic over 160 by 110, and proteinuria more than 300 in 24 hours, or on a spot 300 milligram per gram. So dipstick to a non-specific है, we know serum uric acid level above 4 may be associated. Creatinine of 1 may be considered abnormal in pregnancy, but as such does not predict risk, or generally outcomes are good if it's less than 1.5 creatinine during pregnancy. Or uterine artery Doppler may be useful between 16 to 22 weeks, and that may identify pregnancies at risk for preeclampsia and small fetus for gestational age. So, which brings us to this 50-year-old female comes to clinic with a recently discovered history of high blood pressure for 4 months and screening test electrolytes. As shown, she has no episodic palpitations, no history of diarrhea, vomiting, or diuretic use. And today, her blood pressure times three, 1 minute apart, seated position with an automated device, unobserved, has a mean of 155 by 95 millimeters mercury. CB3 shows hemoglobin 13.2, sodium is 142, potassium 3.4, bicarb 28, and the repeat potassium is also below 3.5. She should now first undergo screening for
Sir, hyperaldosteronism
excellence.
and
Well, that will be the first. That should be the first choice. May be present in most patients without hypokalemia, but unprovoked hypokalemia with hypertension should also initiate a search. Pheochromocytoma में थोड़ा सा episodic होगा with palpitation, sweating, restlessness, hypokalemia उसमें भी हो सकता है थोड़ा बीटा टू रिसेप्टर मीडिएटेड एपिनेफ्रिन रिलीफ से इंट्रासेलुलर शिफ्ट्स में हो सकता है उसमें भी थोड़ा बहुत थायरोटॉक्सिकोसिस में बोथ हाइपोकलीमिक और हाइपरकलीमिक पीरियोडिक पैरालिसिस भी हो सकती है और वो यूजली हाइपोकलीमिक और उसके अंदर अपने उसके एसोसिएशंस हैं तो 20 to 30% केसेस में हैव हाइपरटेंशन और लेकिन यहाँ पे वाइड पल्स प्रेशर ज़्यादा होता है और renal artery stenosis of course can present with difficult to treat hypertension or resistant hypertension so to speak. Okay. 75-year-old lady comes to family medicine with recent onset of fatigue, irritability, unsteady gait, recent fall. She is on hydrochlorothiazide, 12.5 a day, lisinopril, 10 milligrams combination pill. So she's on something like a lisinopril hydrochlorothiazide combination for her hypertension. And current exam has a BP of 135 by 80 seated, 125 by 70 standing, and the initial screening test of normality most likely to determine the cause of her symptoms will be.
low serum sodium level.
So excellent. So hyponatremia is a well-recognized anomaly in elderly women. In elderly women on thiazide type diuretics should be suspected with the irritability and recent falls. Hyponatremia obviously is not common with these weak diuretics. High serum potassium can occur with lisinopril alone with renal dysfunction, but neurological features are less likely. And hypokalemia may occur with loop diuretics, but less often with thiazide type diuretics and without neurological features. And thiazide type diuretics rarely may cause hypercalcemia, say. So, a 45-year-old male comes to the outpatient family medicine clinic with recent onset of early fatigue and occasional headaches. And his current examination is remarkable for blood pressures of 128 by 82 millimeters mercury on an average of 3 readings in the office with an automated BP device following 3 months of close observations. Ambulatory automated BP readings, however, reveal average systolic BP greater than 140 by 85 on a 24-hour reading. The initial screening test that may best help in determining masked hypertension mediated organ damage is
It, it could be E.
it is echo. So echo
Echo.
LPH is the most prevalent hypertensive tension mediated organ damage in the above list. EGFR decreases relatively late as a manifestation of end organ damage. Ankle brachial index changes also are late manifestation. Or if you're looking at ECG LVH, that is detected later than echo. And microalbuminuria is also relatively late as a manifestation of hypertension mediated organ damage. तो वो जो subtle चीजें जो echo में नजर आती हैं वो सबसे पहले नजर आती है seems. Okay, which brings us to this case vignette where a 65-year-old female comes to hypertension clinic with occasional headaches and fatigue for the past 4 months. She denies episodic restlessness, palpitations, or sweating. She has no family history of hypertension. Her BMI is 30. Her current exam is remarkable for BPs of 150 by 90 on an average of three unobserved readings with an automated BP device and an average uh, of 142 by 88 on three readings on the second visit. Initial screening physical exam does not reveal any S4 or renal bruise, and her serum creatinine is zero point 0.8. Her urine exam and ultrasound kidneys are normal. You should not next order.
Sir, plasma free metanephrines.
So here you कहते हैं बस ECG would be appropriate in this case in amongst this list to determine LVH और सीरम कोर्टिसोल डेक्सामेथासोन टेस्ट अगर आप सस्पेक्टेड कुशिंग सिंड्रोम में वो लेकिन वो अप्रोप्रिएट नहीं है सेटिंग में PRA to aldosterone ratio would be indicated अगर suspected renal artery stenosis या primary aldo के अंदर लेकिन ये भी कंसिडरेशन इस केस में नहीं है इलेक्ट्रोलाइट सब्सिक्वेंटली करा सकते हैं विद द सीरम क्रिएटिनिन एनी हाइपोकैलेमिया में पॉइंट टुवर्ड्स aldo hyper aldostate and plasma metanephrine in episodic hypertension और नीड टू रूल आउट फियोक्रोमोसाइटोमा उसमें ये आ जाएंगे तो मतलब नहीं इसमें जाहिर है हर चीज का मतलब सारे ये इस केस का यही है कि आपके पास कोई भी राइट आंसर 100% नहीं है मतलब बेस्ट आंसर्स में कोई एक नेक्स्ट स्टेप हो सकता है एवरी आंसर कुड बी appropriate in the right clinical setting and nobody can fault anyone except that we have to be a little cost effective especially in resource constrained countries like ours. So her ECG is shown here. You may now consider ordering what?
कुड बी सर इकोकार्डियोग्राफी एंड रिस्क प्रिडिक्शन के लिए फिर लिपिड प्रोफाइल कर लेंगे इसका.
हाँ ये सारे सही हो सकते हैं लेकिन इस पर्टिकुलर केस में क्योंकि जो है वी डोंट नो कि इस पेशेंट को मास्ट हाइपरटेंशन है या वाइट कोट हाइपरटेंशन है तो 24 आवर एम्बुलेटरी ब्लड रिकॉर्डिंग इज सजेस्ट. So, so to determine possibility of office or white coat hypertension, ये हमने 24 आवर करना है और उसमें if the average BP is less than 130 by 80 या डे टाइम is less than 135 by 85 या night time is less than 120 by 70. So this may be diagnostic कि what she's presenting to in the clinic was white coat hypertension or वो उसमें भी there was no evidence of any ECG changes also on that. ECG it was normal. 2D echo, of course, optional test है, recommended by AHA guidelines, can pick up LVH earlier than EKG or Doppler ultrasound जो kidneys का है, वो can be used as a screening test. इसकी अच्छी अपनी sensitivity है to rule out renal artery stenosis. Excuse me, when indicated for workup of resistant or secondary hypertension, or the thyroid function test may be appropriate in the right setting, as both hyper and hypo may be associated with hypertension. Or lipid profile should also be considered after establishing the diagnosis of hypertension to determine your coronary risk score, your appropriate targeted interventions. Once hypertension is confirmed, you should now consider treating her to a target blood pressure of less than 130 by 80 with
So it's single drug. It could be hydrochlorothiazide because she's elderly, and it can be amlodipine plus valsartan as well.
Yeah.
Because she has LVH.
Right.
So yeah, amlodipine. I will go with amlodipine and valsartan combination.
Okay, so excellent. So so in combination, targeting both these sites minimize the respective side effects of the calcium channel blockers, and as well as for minimizing, and according to the guidelines. So I will just mention to one of our participants that we'll share recording. We'll share recording. Okay, inshallah. So, hydrochlorothiazide may be considered as a later add-on, but is no longer considered as an isolated first choice. आज लोग में कर सकते हैं अगर बिल्कुल ही borderline grade 1 hypertension है without any end organ damage. बट आमतौर पे गाइडलाइंस आजकल कॉम्बिनेशन की बात कर रही हैं क्लोथैलिडॉन अर्ली स्टेजेस ऑफ क्रॉनिक किडनी डिजीज एडिमेटर स्टेट्स में आजकल लोग कह रहे हैं स्पेशली मतलब थोड़े से मोर एडवांस उसमें कंपेयर टू जस्ट हाइड्रोक्लोरोथाइजाइड क्लोथैलिडॉन थोड़ा ज़्यादा इफेक्टिव है मेटोप्रोलोल इज रिलेटिवली वीक एंटी हाइपरटेंसिव लेकिन जो इस्कीमिक हार्ट डिजीज में और डिक्रीज लेफ्ट वेंट्रिकुलर सिस्टोलिक फंक्शन के अंदर भी जो है जस्ट टू डिक्रीज द वर्कलोड वहाँ पे भी काम आ सकता है और डिल्टाइजम थाइजाइड के कॉम्बिनेशंस को ज़्यादा इतना पॉपुलर नहीं है. She now follows up in 1 month, and her blood pressure on an average is 158 by 94, despite adherence to amlodipine, valsartan, and a creatinine is zero point 0.8. You now increase the amlodipine, valsartan to 10 by 80, but she develops edema. So you should consider switching to.
Uh, the chlorthalidone can be added, and or on other end, amlodipine can be minimized and valsartan can be increased at the same time.
Right. I think that is appropriate. And so you can
Mm.
do that. And so, especially if the higher dose amlodipine leads to vasogenic edema, then just simply changing the combination within might be one thing. Adding furosemide as a loop diuretic can be considered if there's chronic kidney disease and edematous states. Clothalidone can be used in the context of heart failure, liver disease, or advanced kidney disease as well. Atenolol may be considered if there's ischemic heart disease, and labetalol, in this case, is not indicated at this stage. So, based on patient preference, you added clothalidone instead of a within combination switch, and she comes back in a month with a BP now 128 by 80 on 3 separate occasions, and she has fatigue, and her investigations is least likely to reveal.
Hypokalemia, sir.
So ये सारे चीजें पॉसिबल हैं बट डिक्रीज यूरिक एसिड लीस्ट लाइकली है ना बिकॉज
Yes, uric acid, uric effect has.
राइट
Yes.
तो
Mm.
thiazide type diuretics will usually cause hyperuricemia. Pre-renal azotemia is possible with ARB, chlorthalidone, BN creatinine ratio बड़ा बढ़ सकता है. Thiazide diuretics may be associated with mild hypokalemia, ARBs with modest hyperkalemia, hyponatremia.
In the previous,
Thiazide, जी.
sir, sorry to interrupt. In the previous case, we didn't add, I think, thiazide
Yeah.
diuretic.
We didn't. In this, but we wanted to do the intra thing change, and we wanted that, and that was
Mm.
appropriate. But the patient had decided on the diuretic wala combination. Then this thing can be
Mm.
taken. Case B is a 55-year-old male with a 20-year history of diabetes, CKD stage 3, EGFR 40 with BUN 45 and creatinine 2.2. And EF is 45% on 2D echo. He's on insulin, SGLT2 inhibitor, GLP-1 RA with hemoglobin A1C 8.5. He has uncontrolled hypertension on his past 3 visits with mean readings about 150 by 94. His blood pressure medications included amlodipine, valsartan, now 5 by 160 twice daily. He has an S3 gallop plus an S4. He is referred to nephrology from cardiology, and you should consider at this stage adding.
The furosemide would be the better option.
There are 2 furosemides.
So keeping his creatinine can be between 160, and he has so it will be adding at higher doses, 80 mg daily.
Right. So in this particular case, you will add the higher dose 80 milligrams. So Basically, the rule of thumb is that creatinine multiplied by 40 gives you a dose of likely loop diuretic effectiveness for furosemide. And so we add something which is likely to work, especially in these cardiorenal syndromes, where once they decrease your preload, they will improve your cardiac output also. Chlorthalidone is superior to hydrochlorothiazide, but will be less effective than loop diuretics. Low dose furosemide will be less likely to be filtered and work on the luminal side to block your sodium potassium 2 chloride channels. And valsartan, sacubitril can be useful, but are weaker antihypertensives. Uh, According to ACC/AHA guidelines, either one of metoprolol, bisoprolol, or carvedilol can be considered for heart failure with reduced ejection fraction, but atenolol, particularly in decompensated heart failure, would be contraindicated. So he comes back the following week with furosemide 80 milligrams daily added, and his blood pressure is 140 by 86 on an average. He has gained 2 kilograms, still has an intermittent S3 gallop, and has occasional RALs. His sodium is 138, potassium 5.1, chloride 100, bicarb 25, Bunt 52, creatinine is now 3. You should now decrease his furosemide, decrease his amlodipine valsartan, increase his furosemide, advised to consider biventricular pacing.
So would go for further increasing the dose of furosemide.
Excellent. So an increase is indicated to relieve the chest congestion, improve clinical outcomes. So even if that permissive increase in creatinine, there's no problem. That is associated with improved outcomes in terms of decreased rehospitalizations for these cardiorenal syndromes. And but you also, by decreasing the preload, you may actually BU and creatinine may decrease subsequently. And a decrease in furosemide would worsen the heart failure and renal functions. A decrease in amlodipine valsartan may worsen again heart failure and renal function. Although in conditions of overdiuresis, this could be considered. And biventricular pacing in advanced left ventricular failure might be fine. So he comes back in 4 months to the emergency room with sudden onset dyspnea and a blood pressure of 190 by 120. He has diffuse RALs and S3 gallop and is now noted to have a faint systolic diastolic aortic bruit. Creatinine is now 3.6. Electrolytes show sodium 130, potassium 4.5. The next screening diagnostic step after high dose loop diuretics and stabilization should be.
Sir, this patient has resistant hypertension, so I would suspect for renovascular hypertension in this patient.
Mhm.
I think the initial screening would be Doppler ultrasonography of the kidney.
Yes, excellent. डॉक्टर अस्मा अस्सलाम वालेकुम वेलकम. सॉरी आप लोगों को मेरा
वालेकुम सलाम सर.
कंफ्यूजन हो गई शुरू में, but we have gone through quite a few cases, but we are recording this. So inshallah we will share with all who are joining a little later than the initial time, and so we'll continue. So we've just gone through most of these case vignettes initially, but there's a quiz at the end, and this is also being recorded. So
ओके सर.
Thank you. So Doppler ultrasonography would be a useful, non-invasive, cost-effective screening test to rule out renal artery stenosis. And renal angiography may pose undue high contrast toxicity risk, but would be a subsequent definitive step with angioplasty stenting if there's very high suspicion of renal artery stenosis. MRA with gadolinium may be useful as a screening test with mild CKD, but poses progressive risks of systemic nephrogenic fibrosis at this advanced level of renal dysfunction. And CT angiography again would have radiocontrast nephrotoxicity, and we may not want to use it as a screening test. He stays in the coronary care unit for 3 days and with aggressive diuretics given as furosemide 160 milligrams IV followed by 10 milligrams hourly infusion. We expect the following in his lab parameters next day.
So what's in renal functions?
सर अगर हाइपरकलीमिया है तो सर वो डेफिनेटली इंप्रूव करेगा विद फ्रूसमाइड हाई डोज. एंड सर इफ देयर इज renal artery stenosis, then there will be worsened renal functions.
Okay. So, yeah, I mean, like if you are using, if you have bilateral renal artery stenosis, So all those things are true. But if you have unilateral renal artery stenosis and you have hypertension and heart failure as a result of that, then by improving your preload and bringing the blood pressure down, your cardiac output should actually improve and your renal function should improve. Okay, because that will lead to restoration of your Starling's curve. A worsening of renal function, less likely once you're in the compensated state of heart failure. Hyponatremia will likely to improve when your ADH effects are overcome. In well-controlled diuretic regimens, hypernatremia is not noted, and hyperkalemia is less likely with higher dose of loop diuretics. Although, if you have uh, worsening renal function and ARBs, you can get hyperkalemia also. So, there's again, I mean, like it's a matter of a judgment call. You might say, no, I challenge this answer, and you may come up with good justification. But practically, when you see these kind of patients who go into flash pulmonary edema and all that, if you reduce their blood pressures, then because that's how a lot of these people present. I mean, the ones with the bilateral renal artery stenosis, of course, they get worse renal function with all these measures. At a follow-up visit in a week after discharge, the blood pressure has shown an improvement now to 132 by 80 millimeters mercury on amlodipine, valsartan 560, 5 by 160 twice daily, and furosemide 120 daily. Renal Doppler ultrasound has ruled out renal artery stenosis. His creatinine is now 2.8 with a potassium of 5.3. You should now advise dietary potassium restrictions and
Sir,
So
I
we
will
go with
choose the
D.
B option. Renal function and electrolytes in 1 week.
Absolutely. So renal function electrolytes should be repeated in a week to ensure steady state and an improvement in potassium with dietary restrictions. Renal angiography is not indicated, especially with a negative Doppler ultrasound and high risk for contrast toxicity. And a decrease in antihypertensive medication is not indicated at this level of blood pressure and borderline potassium. Regular follow-up in 2 months without following serum potassium may be risky. A repeat 2D echo is unlikely to yield additional information of value. So after this initial 10 questions and the two vignettes with five subsequent stations each, so we've gone through about 20 different scenarios of a diagnostic approach and an initial therapeutic approach to some forms of primary hypertension, previously known as essential hypertension, and some forms of screening for secondary hypertension. And in fact, some may be even considered resistant hypertension. So these were just some examples. And then now we will see that, what is the state of hypertension in the year 2025 and how does it differ from some of the guidelines of 2024 and 23. So we have about 1.28 billion adults aged 30 to 79 worldwide who have hypertension, but unfortunately, two-thirds of those are living in low and middle income countries. And an estimated 46% of adults with hypertension are unaware that they have the condition. So one in two don't even know. And less than half of adults, 42% with hypertension, are actually diagnosed and treated. And approximately one in five adults, 21% with hypertension, have it under control. It's a major cause of premature death worldwide. And one of the targets for non communicable disease by WHO is to reduce hypertension by 33% between the years 2010 and 2030. So I wrote this small blog a few months ago on the day of the World Hypertension Day because it's really something that it's not just one in four, one in five. I mean, in our parts of the world, it's almost like one in three Pakistanis now have hypertension, which is often undiagnosed, and we have so many different issues that need to be done, and policies and practices have to be targeted to prevent stroke, heart and kidney disease, and all the other complications. So, a quick review of the pathophysiology. The factors which may increase your blood pressure include obviously unopposed RAS actions, renin-angiotensin aldosterone axis, sympathetic nervous system, the unopposed endothelins, arginine vasopressin, and the role of the metabolome in leading to high blood pressure. These are supplemented by environmental factors, the ambient temperatures, the noise exposure, the air pollution, and then, of course, some of our lifestyle factors like diet, alcohol, smoking, inadequate physical activity, poor sleep quality, and stress. And then they are exacerbated if you have monogenic or polygenic inheritance for hypertension related genes. But there are some good factors like the nitric oxide as a vasodilator, the natriuretic peptides, the prostacyclins, the adiponectins, the adenomedallin coming from the kidneys, the gut microbiota, the flora. So all these things, it's a balance. And if you have unopposed activity, whether it is at the level of the brain with the sympathetic nervous system activity, or the level of the kidney with angiotensin 2 and aldo, at the level of the heart with your cardiac output being increased by whatever reason, with stroke volume and heart rate being the factors, to the level of the systemic arteries with increased stiffness of the vessels and decreased rarefaction, to the level of the peripheral resistance, all of them lead to an increase in blood pressure. And it, as a review, so we understand why, some of the things like even noise exposure and stresses contribute to high blood pressure in our lives. And I think it's important to be aware of these. So when you're looking at the cardiovascular risk of hypertension, so the Europeans classify hypertension in terms of the grades. They call hypertension only when you have grade 1, when you have 140 to 159 systolic, diastolic 90 to 99, or diastolic 90 to 99. Grade 2, when you have systolic 160 to 179 and or diastolic 100 to 109. And grade 3, when your systolic is over 180 or diastolic over 110. And they refer to 130 to 139 and up to 89 blood pressure as high normal. And it was okay because even in that high normal area, there was really no risk or very low risk if you don't have other risk factors. But when you start having more than two risk factors, more than three risk factors, even in this high normal range, you can have cardiovascular risk starting to increase. And particularly when you have hypertension mediated organ damage or CKD grade 3 or more, or diabetes, then the risk becomes almost high risk. And when you have cardiovascular disease or cardiac CKD greater grade more than 4, then you're in the very high risk. And at all the other higher blood pressures, grade 1, grade 2, grade 3, then unless you have no risk factors, everything has a moderate to high risk. And when you have more than 2 or 3 risk factors like CKD or organ damage or cardiovascular disease, you go into a very high risk for increased mortality. And based on this score, uh, risk score that they had in the past, or the prevent, where when you look at more than 10-year risk of 77.5% of cardiovascular morbidity, then these risks obviously multiply and decrease longevity and have direct impact on or cerebrovascular outcomes, cardiovascular outcomes, renal outcomes, and the like. So when we are taking a history in a hypertension clinic for patients with hypertension, when was it first diagnosed? How many readings were required? Did somebody just label them at the first sitting? What were the records of any previous screening? Is it stable, or is it something that rapidly increased? That is the blood pressure. What were the recordings of current and past BP values by self BP measurements? What are the current and past antihypertensive medications? Were they effective, or were you intolerant? Was there any issue with adherence? Was there previous hypertension and pregnancy or preeclampsia? Then other risk factors, including family history, cardiovascular disease, stroke, kidney disease, smoking history, dietary history, lack of physical exercise, weight gain, erectile dysfunction, sleep history, snoring, sleep apnea, long-term cancer survivor, then history and symptoms of hypertension-mediated organ damage, cardiovascular disease, stroke, and kidney disease has to be specially looked for. Headaches, कि नहीं है, vertigo, syncope, impaired vision, TIA, sensory motor deficit, strokes, previous carotid revascularization, any memory loss, cognitive impairment, dementia, multi-infarct, for instance, heart के लिहाज से chest pain, dyspnea, myocardial infarctions, revascularization, syncope, palpitations, arrhythmias, particularly atrial fibrillation, and heart failure, kidney के लिहाज से kidney-related symptoms, thirst, polyuria, nocturia, hematuria, UTIs, peripheral arteries के लिहाज से cold extremities, intermittent claudication, pain-free walking distance, pain at rest, ulcer necrosis, peripheral revascularization, and CKD ki history, polycystic, for instance. Then secondary hypertension ki things are suggestive like young onset of grade 2 or 3 hypertension in less than 40 years age, or sudden development of hypertension, or rapidly worsening blood pressure in older people, history of repetitive renal urinary tract disease, repetitive sweating, headache, anxiety, palpitations, which may suggest pheochromocytoma, spontaneous or diuretic induced hypokalemia, episodes of muscle weakness and tetany, which may suggest hyperaldo, symptoms suggestive of thyroid disease or hyperparathyroid, history of current pregnancy, postmenopausal state, oral contraceptive use or hormonal substitution, and then recreational drug abuse or use non-prescription drugs like glucocorticoids, NSAIDs, COX-2 inhibitors, paracetamol. So this is something that we may not think of very commonly. Acetaminophen is also chronic use is associated with hypertension. Immunosuppressive drugs like cyclosporin, things like that, anti-cancer drugs, mitomycin C, other kinds, nasal vasoconstrictors, decongestants. These are all things that need to be thought of. So I think we have one more person online, and may I see who that is? This is Dr. Azhar. Assalamu alaikum. Welcome.
Welcome, Salam. Sorry, I got tied up at work. Sorry.
Okay. I thought it was my fault initially because the codes that I've been giving, I think I had to generate a new code just because seems like people were not able to enter initially also. But anyway, yeah.
Okay.
But what we have done is that we have recorded this session and we're recording it, and
Excellent.
yeah. So the first 20 minutes or 15 minutes we spent looking at 10 case scenarios and then 2 case vignettes with 5 evolving stations. So we went through 20 of those different forms of diagnostic
Excellent.
therapeutic approaches. So that is there and that's all recorded. And then now we are reviewing this, and in the end, we'll go through the post-test quiz. So yeah,
Excellent.
yeah, thanks. So after the history, now the proper positioning is so important, in the use of a validated automated electronic upper arm cuff device. I mean, these mercury devices that we use are no longer being recommended anywhere in the world. They have a toxicity issue, and we need to get rid of them. The earlier, the better. And there should be a quiet room with comfortable temperature, no smoking, coffee, food, drug intake, or exercise 30 minutes before measurement. Patient should remain seated and relax for at least 3 to 5 minutes. No talking during or between measurements. Sit with back supported by a chair, legs uncrossed, feet flat on floor, bare arm resting on table, mid arm at heart level, and take 3 readings with 1 minute interval between readings and use the average of the last two. If you are in the office, and if you're at home, take 2 readings with 1 minute interval between and use the average. So this is by the European Society of Hypertension, and when you have the American updates on this, pretty much the same, except that they're saying that also make sure the patient has emptied the bladder. And it's such a I mean, like it's such a important factor that we may overlook, that if somebody has a full bladder waiting for us in the clinic, obviously that blood pressure is not going to be reflective of what it may be. And similarly, the device has to be the validated one. And I recently got this Omron one validated one from the States, and I'm now using it as much as I can for, in the clinic or at home. But yeah, it has to be a validated device, use the correct cuff size, and the same things as recommended by the ESH, no talking, and just quiet temperature, and just in a relaxed manner check these blood pressures. But people usually are saying don't even take it yourself. It will be, you should do it unobserved. I mean, like, you may be at the side and somebody is just putting this on, but you are unobserved when you're doing these validated measurements. So direct observation may also affect your office readings. So the devices, the recommended ones are now these electronic automatic upper arm cuff devices, and for office and out of office blood pressure measurement, and with the reference, with the recommendation being level 1, and the level of evidence is level B. Or you can use hybrid manual oscillatory devices with LCD or LED display or digital countdown, or shock resistant aneroid devices, and can be used for the office BP measurements also. If automated devices are not available, that's also 1B. And only properly validated devices should be used level 1B, and cuffless BP devices should not be used for the evaluation. So although these cuffless devices are now coming in, but they have not been validated yet, so they are not recommended yet and may actually cause harm. The office blood pressure is recommended for diagnosis of hypertension because it is the only one method by which hypertension-related risk, benefits of antihypertensive treatment, and treatment-related BP thresholds and goals are based, and this is a level 1A recommendation. The office BP measurement should be in the standardized conditions using the standardized measurement protocol, triplicate in triplicate measurements, and the average of the last two should be referred to as the representative value. Although this is based on a relatively lower level of evidence, it is recommended to diagnose hypertension during at least 2 separate office visits within 4 weeks, unless the office blood pressure in the first go is over 180 by 110. So a small grade 3 hypertension by European Society criteria, or somebody presents with hypertension related symptoms like dyspnea or visual disturbance and others, or there's evidence of hypertension mediated organ damage or cardiovascular disease, and we will see what are some of that evidence. And at the first office visit, BP should be measured in both arms, and if you have a consistent difference in more than 15 to 20, that may suggest atherosclerosis disease, and all subsequent BP should be done on the one with the higher blood pressure reading. So first time, make sure both arms are done, and then whichever is higher, you follow that one in the future. And the out of office BP is a source of multiple BP related information also. And it is also recommended to obtain additional information by either ambulatory blood pressure monitoring or home blood pressure monitoring, or both if available, because we may have mass hypertension or white coat hypertension or mass uncontrolled hypertension or masked or white coat uncontrolled hypertension or just nocturnal hypertension. So there are different things that we will now see subsequently. When we are doing the physical examination, the weight and height should be on a calibrated scale. BMI should be recorded, particularly if you are running a hypertension clinic. The waist circumference is important to document. The signs of hypertension-mediated organ damage can be in the form of subtle changes in cognition or in the neurological examination, or fundoscopy may show various hypertensive stages of retinopathy, or by auscultation of the heart, you may hear an S4 or S3 or carotid bruise, or palpation of carotid and peripheral arteries can also be revealing of peripheral vascular disease or atherosclerosis disease, and ankle brachial index, frequently not done, but also very useful. Then, of course, you can look for cafe or ole spots of neurofibromatosis. One can palpate the kidney and you may feel it if it's polycystic in particular. And of course, one should always try to listen for bruise, particularly if you are, you don't want to mess in the younger age group, aortic coarctation or renovascular hypertension in the middle to later age groups. Then you have certain signs of Cushing's disease or acromegaly that may be pretty obvious, and signs of thyroid disease. So when you're doing hypertension, one should think of hypertension as the source, and then with the spokes of a wheel, you have to see all the other organ systems around it and try top to bottom, and that may be so useful, especially if it's done at the first visit, and then things can be followed if they are abnormal. So I was just mentioning that the European Society have been talking about grades of hypertension, and they have still till 2023, and ECC they're still saying 130 to 139 is high normal, 120 to 129 they're calling it as normal, 80 to 84 diastolic normal, 85 to 85 9 high normal, and they're only going with grade 1 once it's beyond 140 systolic and 90 diastolic. But they also define isolated systolic hypertension as more than 140 systolic, less than 90 diastolic, or isolated diastolic hypertension where your systolic is less than 140, but the diastolic is more than 90. But they still, obviously, they also suggest that optimal blood pressure is less than 120 by 80. Now, if you look at the American Heart Association and ACC guidelines of 2025, they are saying that this blood pressure, which you are calling normal here, 120 to 129 and 80 to 84 or high normal, they are saying this 120 to 129 is elevated blood pressure, and with a load less than 80 millimeters. And when you go above 130, they are now, obviously, this is not grade, this is stage now. They are just restricting themselves to two stages. 130 to 139 is stage 1, and 80 to 89 is diastolic, either one of them. And similarly, stage 2 is more than 140 and more than 90. So if you compare them to European, then what is grade 1 hypertension out here, uh, and grade 2 hypertension is all combined into stage 2 hypertension by the Americans, and something which was considered elevated blood pressure, but not grade 1 hypertension by the Europeans, is considered stage 1 hypertension by the American Heart Association ACC new guidelines. And this is a change that has been coming in last 1 or 2 years, and it's mainly related to those same risk factors, that as you progressively go up above 120 by 80, and if you have some chronic kidney disease or cardiovascular disease or peripheral vascular disease, your risks of poor outcome and hypertension-mediated end organ damage progressively increases. So one may not fault the Americans here for trying to just label somebody hypertensive, but then you can imagine with insurance and other things being such a big issue in that part of the world, it can have pretty significant financial connotations in the same on the same hand, especially in something which is not often diagnosed and not often controlled, like we said. So the 12 lead ECG for the basic hypertensive mediated end organ damage, the 12 lead ECG is the most convenient, and that is something that was used for screening for LVH. But the Americans suggest, ACC, that if you do echo, you might see evidence of LVH before the 12 lead EKG LVH. The urine albumin to creatinine ratio, obviously, to screen for CKD, serum creatinine and EGFR for CKD. The echo to evaluate not just the structure but also the functions of the heart, whether you have hypertension, heart failure with preserved ejection fraction or reduced ejection fraction, or simply LVH alone, and then of course you can have peripheral wave velocity, which also looks at a pulse wave velocity, which also looks at aortic and large artery stiffness. This is becoming quite quite a routine in certain cardiology centers in the United States, perhaps in Britain as well. The carotid artery ultrasound to look at intima media thickness and for stenosis might be considered in the right setting. The coronary artery calcium score obviously can predict CAD events. The abdominal ultrasound, particularly in those over the age of 60 or 70, screening for aortic aneurysms and those which are more than 5 centimeters. I think that's important to document at the initial screening. And one can also do the ultrasound kidneys to look at the size and any discrepancy or Dopplers for resistive indices, and and you can do the ankle brachial index to determine extent of lower extremity atherosclerotic disease, the retina microvasculature to detect microvascular changes, and cognitive testing such as MMSE for early stages of dementia, or one can consider imaging as well. So as we can see, all systems can be affected here, and no one is suggesting that all these tests need to be done, but they have to be targeted, especially in cost, uh, constrained environments. So what are the 2023 ESH criteria to define hypertension-mediated organ damage? The LVH with the criteria of S and V1 plus R and V5, the Sokolov-Leon classical criteria, more than 35 millimeters, or the R wave in AVL, more than 11 millimeters. LVH criteria can be through the Cornell voltage criteria as well. The LVH criteria on echo are, I think too complex for us to look at, but there are certain criteria for all these, and for your left ventricular systolic pressure and dysfunction and filling pressures. Similarly, for the kidney, of course, we know that EGFR less than 60 is something that would define chronicity, and albuminuria more than 30 milligrams per gram is considered moderately severe albuminuria. Renal resistive indices more than 0.7. Then the large artery stiffness through the pulse pressure being more than 60. Now, this is important because a lot of elderly people have low diastolic pressures as they keep aging, and the pulse pressure is more than 60. You may be very cautious in bringing the systolic down if the diastolic is already below 70, for instance. So you may have a pulse pressure of 70, 80, 90. Systolic may still be 150, 160. There may be chronic kidney disease, but in order to bring the pressure down, one needs to see the connotation of bringing the diastolic lower down and causing inappropriate or inadvertent falls. So, but then there are other things that you can do: the ankle brachial index, or the calcium coronary artery calcium score, and of course, looking for grade 3 or grade 4 hypertensive changes and documenting them. So all these are criteria to define hypertension mediated organ damage. So if you're not going to do ECG or echo or the renal functions, or at least one should try and do the ankle brachial index and the eye fundoscopy, and documenting the changes there in terms of arterial narrowing and subsequent advanced changes. Now, just as a review, in general, whatever we see that is in green in this presentation, there will be a level 1 evidence. Class of recommendation would be level 1, which means that there is general agreement that the procedure or the recommendation is actually suggesting something beneficial, useful, or effective, and that benefits clearly outweigh the risk. 3, whenever you see something in red, it may actually be something that is not shown to be beneficial or may actually be harmful, and the risk may be outweighing the benefit. And in yellow means that this is a yellow light. You can go or you can stop, and it has some conflicting evidence, there's some uncertainty. And similarly, level A, B, and C levels of evidence. A would come from randomized control trials or meta-analysis of randomized control trials with cardiovascular outcomes. B would also be randomized control trials, but with surrogate measures. Now, so some of you who have gone through our clinical trials and other workshops, you now know that the surrogate markers are not hard clinical markers, but they are somewhere in between. So there are RCTs that are necessitated to be done with surrogate markers, but then the level of evidence will go down to B, and some good observational studies with low level of bias would also be B. But anything which is observational studies alone with surrogate markers has to be downgraded down to C, because or if it is associated with just with an expert opinion. So whenever we see green, good, red, harmful, yellow, conflicting, and then A, B, C, of course, the higher level of evidence or lower level of evidence. So now let's look at what white coat hypertension is. So it is an out of office blood pressure measurement by either automated blood pressure monitoring or home blood pressure monitoring should be done whenever you suspect white coat hypertension, particularly where you have people with grade 1 hypertension. So if somebody comes in the clinic and by the European Society and they have a blood pressure between 140 to 159 and 90 to 99 respectively systolic diastolic, I think we need to bring them back in 4 weeks and with some, low salt and lifestyle modification, but also consider white coat hypertension. And so if they can afford ambulatory monitoring, fine. If they cannot, then home blood pressure monitoring should be also advised. And assessment of these people of cardiovascular risk factors and the hypertension mediated organ damage is also recommended. Doesn't mean that just because somebody you've labeled as white coat hypertension, we're going to forget about them. There will be white coat hypertension which is untreated and which can cause increased cardiovascular morbidity, as we will see now. So out of office blood pressure measurements, either by ambulatory pressure monitoring or home blood pressure monitoring and repeated during follow-up to timely identify sustained hypertension or new hypertension mediated organ damage is also level 1B. I mean, from the category of recommendation, it is level 1. In patients with white coat hypertension, lifestyle interventions are recommended. And whether lowering blood pressure blood pressure lowering treatment should be used is unresolved, but those in whom there is some evidence of hypertension mediated organ damage and otherwise high cardiovascular risk, as defined as over 7.5% by the prevent calculator, they could also be considered for treatment. And this is level 2, somewhere in between. You may or may not do it. You can observe. And of course, these are from observational data still so far. Now, what about mass hypertension? Again, mass hypertension, you are, okay in the clinic, but there are some evidence of end organ damage or hypertension mediated organ damage, and you want to make sure that they are not hypertensive at home. So you do your, again, out of office blood pressure, either by ambulatory blood pressure monitoring or home blood pressure monitoring, and to identify these people who are at high risk for having mass hypertension at home. And this is also level 1B evidence, because this can also lead to poor consequences in terms of cardiovascular outcomes. In patients with masked hypertension, lifestyle interventions and close follow-up are recommended to reduce cardiovascular risk and to also timely identify sustained hypertension and new hypertension-mediated organ damage. Again, whether you should be treating them or not, or consider to treat them, is something that will depend on presence of hypertension-mediated organ damage and high cardiovascular risk. Now there's something known as watch and much. So you have white coat uncontrolled hypertension and masked uncontrolled hypertension. So the same, these are the same recommendations that you will do the same home blood pressure and ambulatory monitoring, except that these are people who are actually treated. So you sometimes treat people with white coat uncontrolled hypertension and masked uncontrolled hypertension. And you may have whether you need to, bring them to ideal blood pressure levels and all that, that is not well defined yet. But then you can also have isolated systolic hypertension in the young. So anybody who has a systolic BP of more than 140 or and diastolic less than 90 may show up in the clinic. They may be young people, 18, 19, 20 years old. And there can be, again, a white coat effect, or there can be whatever it is, you need to consider the home blood pressure monitoring again in these people. And so, particularly if they have some cardiovascular risk factors or hypertension mediated organ damage. So, out of office BP should be documented in these people also to see whether they're actually in this group. But they should have close follow up and lifestyle interventions. So, just because somebody has a blood pressure of 145 and diastolic 80, can't ignore them. They may have isolated systolic hypertension in the young, and one needs to follow them closely as well. You can have isolated diastolic hypertension at any age, again, more than 90 diastolic and less than 140 systolic. And again, these people need to be, there's a category of recommendation as level 1. So for periodic BP evaluation, lifestyle interventions, and BP lowering drug strategy if they have all the other evidence of hypertension mediated organ damage. What about nighttime hypertension? Some people will have nocturnal hypertension, and they will be either. So normally the blood pressure should be, you know, the highest in the morning, and then you go up. By the time the day goes, it should come down, and in the middle of the night there should be a dip. But then there are some people at like 4 o'clock, 5 o'clock, they are either they don't dip, the blood pressure doesn't go down, or they may be reverse dipping. Blood pressure may actually go up. And those are the people who get heart attacks at 4 or 5 o'clock in the morning. And that can be, so these people need to be identified. Again, you can only identify them if you're going to do the ambulatory blood pressure monitoring, because most people will not be able to do your home monitoring in the middle of the night. But these isolated nocturnal hypertension people also may need to be treated. And but in general, if there used to be some practice recommendations earlier on that use most of antihypertensive at night to prevent the early morning rise and all that. That does not seem to affect outcomes much, and that's a level 1 recommendation. So it doesn't matter whether you dose your medication in the morning or evening. So, which brings us to this particular thing. It's just the same thing. It reiterates the same thing, that if you have high blood pressure in the office setting and high blood pressure out of the office at home, if you don't have them in both these settings, then you call sustained normotension. If you have high blood pressure in both the home and in the office, that's sustained hypertension. If you have high blood pressure in the office, but in no high blood pressure in the office, but yes, at home, that's mass hypertension. If you have high blood pressure in the office, but no at home, that's white coat hypertension. And the same classification is there, even if you're taking antihypertensive medications. So you will call them mass uncontrolled hypertension or white coat effect, depending on how they behave in an office setting or at home. This is the same thing. Now, what are some of the screening guidelines for selected lab work for anybody who's been diagnosed with hypertension? They want you to get a hemoglobin and hematocrit, one of the two, a fasting blood glucose and an HbA1c, screen for diabetes, do the lipids with total cholesterol, LDL, HDL, triglycerides, do your chemistry, including your creatinine, your sodium, potassium, the uric acid, and a calcium, and do your urine analysis and a multi-component dipstick, followed by urinary albumin to creatinine ratio microscopic examination as required. We understand that the ratio will be the most specific, but then these can also pick up some subtle GNs and other things that we know. Okay, so when we are looking at secondary hypertension, you can have a lifetime risk of secondary hypertension starting from the very young age, where you can have mild aortic, mid-aortic syndrome or coarctation of the aorta between the ages of 1 to 18, more or less. You can have renal parenchymal disease at any age, as we know. You can have renovascular hypertension, particularly the fibromuscular dysplasia, in the age groups up to 40, 50 or so, particularly in women. But then the renovascular hypertension with the atherosclerotic disease, when you start becoming more than 50, 60, and greater than 65. You can have monogenic disorders of inheritance present throughout in the early, childhood and youth and adulthood. Cushing syndrome, usually in the 40s to 60s age group. Pheochromocytoma, paragangliomas can occur again from 13 to 60. Primary aldo from 19 to 60, 70. So you have a full spectrum. And if you're doing a primarily adult practice, so then most of the things will be starting from here. After the age of 18, these things will be seen, but a lot of people here have been diagnosed and they'll come into our practices from the pediatricians. So what are some of the features that would raise suspicion of secondary hypertension? Anyone who's less than 40 and has grade 2 or 3 hypertension or hypertension of any grade in childhood, sudden onset of hypertension in individuals who have previously been normotensive, acute worsening of blood pressure and control in those who were previously controlled, a true resistant hypertension. How do we define that? We'll talk about it. Those who present with hypertensive emergencies, those who present with grade 3 or malignant hypertension, those who have severe hypertension-mediated organ damage or clinical or biochemical features suggesting endocrine causes, or those who have features suggesting renovascular disease, or those who have a high big collar size, more than 17 and a half, daytime snoring and nighttime apneic episodes suggested by obstructive sleep apnea, very frequently underdiagnosed things. But now I think more and more awareness is happening in society where obstructive sleep apnea is being recognized as an important cause of hypertension. And of course, hypertension in pregnancy, or depending on whether it is an acute worsening or a new onset, hypertension in pregnancy has to be also thought of as one of the causes of secondary hypertension. So if you have hypertension specialists, or you want to be a hypertension specialist and you want to establish a hypertension clinic, you can market it as something where you are dealing with secondary hypertension, because hypertension is everyone's business. It's the primary care, family medicine, GP, cardiology, nephrology, endocrinology, anybody's business. But when you have suspicion of secondary hypertension, that's where you create a hypertension clinic for secondary or resistant hypertension. And patients who are young, or patients who have grade 2 or 3 hypertension in whom secondary hypertension is suspected, these are ones should be referred to that clinic. Patients who have sudden onset or aggravation of hypertension, patients who are treatment resistant, patients who need more detailed assessment of hypertension mediated organ damage, or who need some in-depth specialist evaluation, or those who have hypertensive emergencies, and they should subsequently be going to hypertension specialists in the field. So what are some of the features suggesting atherosclerotic renovascular hypertension? Well, it is amongst the secondary types. It's about 6 to 14% is this prevalence of renovascular disease. As we know that this secondary can be about 10 to 20%, and out of them, 90% are renal, and out of them, about 90% are renal parenchymal, but the rest, 6 to 14%, can be atherosclerotic renovascular disease. You can present with resistant hypertension, flash pulmonary edema, rapidly declining renal functions, especially with ACE or ARBs, and generalized atherosclerotic bruise. Then your Doppler renal ultrasound is a very good screening test. Otherwise, CT angio or MR angio, further workup with the same, and then going on to a catheter angiography, and treatment, of course, directed at the cause, whether it is in terms of angioplasty or revascularization or ACE inhibitors, depending on whatever you get, and if you have unilateral disease. And then these end organ damage and other things can be also assessed at that assessment. The fibromuscular dysplasia usually will occur in women. They will have early onset, severe hypertension with migraine, pulsatile tinnitus, And again, the same kind of renal Doppler ultrasound would be a good screening test, and angioplasty, but without stenting in these people. And follow-up can be done regularly. And a lot of these people will require 24-hour ambulatory blood pressure monitoring also, to look at different times of hypertension. And these are also usually non-dippers. So in general, for atherosclerotic renovascular disease, the Doppler ultrasound has a very high sensitivity, 91 to 100%. So if somebody says they can't find anything, the resistive index wasn't high, no evidence, then I think if they are good operators, we should believe them. And similarly, if the MRA also rules out, we should believe that. But obviously, the catheter angiogram will be 100%. And in general, if somebody says somebody has renal artery stenosis, the specificity is not more than 90%. It can be even as low as 82%. So if you want really evidence for after that, you can go with the CT angiogram, or you go straight with the renal angiography. What will suggest pheochromocytoma or paragangliomas? Again, the prevalence is not that common, less than 1%. You have paroxysmal headache, sweating, palpitation, and increased heart rate, BP variation. A lot of these people may be orthostatic, so they may be getting orthostasis with the epinephrine secreting pheochromocytomas in particular. The norepinephrine would be more vasoconstrictive, but the epinephrine ones can cause some vasodilatation also. And so the first choice screening test is plasma or urinary free metanephrines. And in Pakistan, I'm not sure how many centers have this. Some are still doing the good old VMA and all that, but I think that has a lot of false positive in there. So further workup, you'll do a contrast-enhanced CT or MRI and some functional imaging, and then surgical resection, of course, with the appropriate preparation is the key for these people. But primary aldo is something which is more common, 6 to 20% out of these secondary hypertensions, and you frequently miss it because you're always looking for that low potassium, which is not there in more than 40, 50% cases of hypertension. So in hyperaldo states. So again, these people will present with resistant hypertension, grade 2 or 3 hypertension, hyperkalemia in the low normal range, atrial fibrillation, obstructive sleep apnea, and things like that. And the plasma aldo to renin ratio would be pretty diagnostic and suggestive, but you can also do the CT scan and other specific tests, including ending up with adrenal vein sampling. And then, of course, that can define whether you have unilateral or bilateral adenomas or adenocarcinomas, which are secreting that aldosterone. And the treatment is obviously laparoscopic adrenalectomy is what is considered, or you can do medical treatment if you have bilateral adrenal disease, and that is another thing that can be offered to these patients. Moving on to Cushing syndrome, again, the prevalence amongst these secondary is about 2 to 5%. Again, these people may have resistant hypertension. There's a typical body habitus with the facial plethora, moon facies, and proximal myopathy. And you can do the overnight 1 milligram dexamethasone suppression test as a good screening test, and the 24-hour urine-free cortisol, and then further workup accordingly. And then the treatment can be medical or surgical, according to what we find. Aortic coarctation, younger age group, less than 30, 0.1% prevalence. Cushing syndrome, again, not very common. Primary hyperparathyroidism is rare, but can also cause hypercalcemia-related hypertension. Congenital adrenal hyperplasia symptoms, the 11 beta hydroxylase and 17 alpha hydroxylase deficiencies can lead to the elevated precursors of cortisol, and which causes hypertension. And similarly, the mineralocorticoid excess syndromes, other than primary aldo, can present with some of these resistant hypertensions, and even acromegaly, we should not forget. Both hypo and hyperthyroidism can cause hypertension, as can paragangliomas, and they will have their specific clinical features. Which brings us to the this article, which has still not been published. I haven't seen the published form except in the draft form. So I think that is why something that we are doing in this workshop is time is of essence, because this is something that's just off the cuff. It has just come out. And there are some other new kids on the blog. So we'll just take a quick look at some of the newer recommendations here. But in general, they're saying that whenever you have a low 10-year cardiovascular risk, as defined by the PREVENT calculator, which we'll see in a subsequent slide, of less than 7.5%, you will usually have 3 to 6 months of monitoring with lifestyle modifications. And if when the blood pressure is even, according to the American College of Cardiology, 130 to 139 and 80 to 89, as we saw, they're calling it as stage 1 hypertension. But even there, they wanted to wait 3 to 6 months. And after that, you can try and define what organ systems are at risk in order to propose therapy. But in general, when you're doing the prevent equations, they are valid for, at least in North America, for adults between 30 to 79 who do not have any cardiovascular disease. But those who have it or have low ejection fraction, all you're not supposed to use that. But they will just, you can put your age range, the total cholesterol, the HDL, the systolic and blood pressure, the BMI, the eGFR, whether they have diabetes or not, whether they're on current medications or not, antihypertensive medications or not, lipid lowering or not, and then what is the UACR, HbA1c, and this is for, at least in some parts they have uh, people going into poor neighborhoods, so the zip code also for their culture. But the key points about some of these take-home messages from the 2025 guidelines are that in all adults with hypertension, initiation of medications to lower blood pressure is recommended whenever the systolic is more than 140 or diastolic is more than 90, to reduce the risk of cardiovascular events. So they are still, although they are saying this is stage 2, but they're saying that, wait till uh, you have, some lifestyle modification and all that, but then you need to start off in order to get the blood pressure. Anybody who's more than 140/90, that needs to be reduced. And then again, when you have hypertension and clinical cardiovascular disease, if your blood pressure is more than 130 systolic, more than 80 diastolic, again, you need to initiate therapy. If you are, again, you have no cardiovascular disease, but you have diabetes or CKD, or at short CVD, cardiovascular risk, you still want to initiate your blood pressure medication when your systolic is more than 130, when you have CKD. But then, and or you have diastolic more than 80. So we know that as nephrologists, all these things. Now, they're saying that those who are overweight, obese, weight loss of at least 5%, a healthy eating diet, the DASH diet, with high vegetables and roughage and things like that, fruits and vegetables, and reducing sodium to, goal is less than 1.5 gram per day, or less than 2.3 initially, but try to come to less than 1.5 gram of sodium. Now, for salt, it is obviously higher level, so 4.5 grams or so. And then you can use potassium-based salt substitutes, but if you do have kidney disease, then obviously don't use those. Then you can use moderate potassium supplementation for those who have mildly elevated blood pressure, hypertension. It acts as a vasodilator and helps in decreasing insulin resistance. So I think that can be useful. And those who have taken alcohol, have them cut down, or whatever you want to counsel them with. And increasing physical activity through a structured exercise program, aerobic and anaerobic, is also recommended. Stress reduction through meditation or other things, these are relatively lower level of evidence. But then they're saying that those who have a cardiovascular risk less than 7.5, and then one can wait for 3 to 6 months before you initiate therapy, particularly if BP remains over 130 by 80, 130 systolic, 80 diastolic. What are some office BP targets for drug treatment? They're saying for ages 18 to 64, target less than 130 by 18, regardless of whether you have kidney disease or not, or whether you have heart disease or not, just target less than 130/80. Those who are 65 to 79, target less than 140 by 80, but if they can tolerate, also try to bring them to 130 by 80. Those who are 65 to 79 with isolated systolic hypertension, target that blood pressure systolic to less than 140, 150, 140 to 150 range. But be careful, because if your diastolic is below 70, you can start having falls. Again, for patients who are over 80, then nothing such as age के साथ blood pressure है ठीक है नहीं. Even there, you want you to bring it down to 140 to 150 range. Yes, not one less than 130, but 130 to 139 may be considered for selected cases. But you have to be cautious that diastolic pressure is not below 70. And then, of course, those who are frail or those who have, so they are saying that don't decrease blood pressure to less than 120 in anyone. And especially if, even in kidney disease, it's actually associated with harm, 120 by 80 or less. So now for the specific categories, they are saying one can use any class of agents as long as they get the blood pressure down: ACE, ARBs, beta blockers, calcium channel, thiazide types, and based on various combinations, the preferred combination should be in a single pill, usually ACE, ARB with a calcium channel blocker or a thiazide type diuretic. And then you can also consider monotherapy in those who have grade 1 hypertension up to 150 in certain cases, who do not have who have normal high blood pressure, high normal, or those with high cardiovascular risk. You can use single agents also, but usually double are being recommended. And then if you're not controlled by two, then you go to a three-drug combination where, apart from ACE, ARB plus calcium channel blocker, you add a thiazide type diuretic. And if it is not controlled with that, then you label that at a maximum as a resistant hypertension, use the single pill combinations, and then you can advance and add your MRAs and other things if you have if you're going into that resistant hypertension category. But you can consider beta blockers in heart failure, or those who require anti-ischemic therapy, or in atrial fibrillation. And then of course, two RAS blockers at the same time is not recommended. High risk of harm by these criteria. So in general, if somebody has grade 1 hypertension and blood pressure in this 159 to 9099 range, then, and if they are asymptomatic without any hypertension mediated organ damage and cardiovascular, then see them again in about 4 weeks and initiate lifestyle interventions. But if they stay over 150 by 95 after 4 weeks, begin the treatment, the dual treatment or whatever, and then try and get them to normal within 3 months. But if they start off with grade 1 hypertension or grade 2 hypertension or grade 3 hypertension, or whether they are symptomatic or have hypertension mediated organ damage, particularly CKD greater than stage 3 or CV cardiovascular, again, start off with your lifestyle interventions, and immediate drug treatment is recommended for these ranges, and try to optimize them within 3 months also. There are some multiple clinical trials with ACE and diuretic combination, ARB diuretics, ARB calcium channel, ACE and calcium channel, beta blockers and diuretic, combination of two RAS ACE inhibitors plus ARB or RAS blocker plus renin thing. And these were then suggestive of more renal events. But everything else, where your systolic blood pressures, even up to the 2 to 5 to 10 range, up to 20 range, led to a significant decrease in strokes and major cardiovascular events, and of course renal events as well. And whenever you have, try and go for a single pill combination. Step one as a dual combination, then a triple combination, and then you can add. And when you have dual combination therapy, it's usually ASO ARB plus calcium channel blocker or diuretic. So you have various combinations available in Pakistan, increased to full dose, up to 60% may be controlled like that. But for some, you will need ACE or ARB plus calcium channel blocker plus a thiazide type diuretic, and up to 90% will be controlled at full dose if well tolerated. But if they're not controlled, then they may be true resistant hypertension, and then they should be referred to specific areas. And of course, there are some who can be still offered monotherapy. But in general, so you have blood pressures in the normal range, elevated range, stage 1 range, stage 2. Everyone suggests lifestyle therapy. Everybody suggests reassessment. Everyone wants you to treat anything over 130, over 80 if they have cardiovascular or renal risk. And everyone wants you to wait for a few months to do lifestyle intervention before you and you intensify drug treatment and get them at target in about 3 to 6 months. So this is something which is just a recap of what we've done. Again, if you have blood pressure levels only without any other evidence of risk, then if it's more than 140/90 and you have you should still sustain 140/90. You should treat them. If you have cardiovascular disease or stroke or heart failure, and have all these risk factors, then again 130/80 is that cutoff where you want to treat them. In general, you could do antihypertensive therapies with single agents also, like thiazide types or long-acting dihydropyridine calcium channel blockers and ASO ARBs. But more and more the recommendations suggesting that at least in stage 2 hypertension, more than 140/90, antihypertensive drug therapy with 2 first-line agents of different classes in a single pill combination are suggested. And then, but if you have 130/39 to 80/89, you might be able to do a single agent as well, but that level of recommendation is lower than the level 1 here. And of course, they don't want you to use ACE/ARB and renin inhibitors in combination. They say that true resistant hypertension would be defined as when you have at least 3 drugs, including one which is a diuretic, and maximized, and you're still over 140/90, or you are controlled to 130/80, but you're on 4 drugs, then you have resistant hypertension, and confirm that whether it is real or pseudo by doing, assessing for medication adherence and also to exclude other secondary causes, and by using ambulatory blood pressure monitoring. But if that is not feasible, you can have them do home blood pressure monitoring. So these are things that are important, particularly for this resistant hypertension. Again, one should try to get them to below 140/90 still, but ideally would be 130/80 also for them. Reinforce their lifestyle measures, add spironolactone or eplerenone or other MRAs, and you can then try other agents also if these are not controlling it, like beta blockers, alpha blockers, centrally acting agents, and thiazide type diuretics or loop diuretics or clothalidone, depending on the GFR. And usually when you have advanced CKD, of course, loop diuretic serves as antihypertensive. Renal denervation, reserved in special centers for those who are resistant hypertension and have GFR is more than 40, may have some value, although simplicity trials initially did not show, but subsequent simplicity ones, I think, showed some benefit. And again, you have to document all these things through ambulatory blood pressure monitoring. So in general, whether it is salt and water retention or activation of CNS, central nervous system, sympathetic nervous system, or RAS, or impaired vascular function, they may cause apparent resistant hypertension. You have to confirm it with ABPM, ambulatory or home blood pressure monitoring. And when you have that, intensify the drug treatment, intensify the lifestyle. And here, sleep apnea, other things might be some of the causes that are not addressed, and one needs to look at those things as well. When your GFR is more than 30 in true resistant hypertension and patients are not controlled with ACE or ARB plus calcium plus thiazide type diuretic, you can add the spironolactone or other MRA or beta blocker or alpha blocker or centrally acting agents or renal denervation. And when you have your GFR less than 30, but not on dialysis, and they are not also controlled on ACE, ARB, calcium channel plus a loop diuretic, then you can add to that loop diuretic a clothalidone or beta blocker, alpha 1 blocker, central acting agents. So in general, resistant hypertension, this kind of just is a summary of the same thing. And you maximize your diuretic therapy, add spironolactone or epinephrine, and use other agents appropriately and refer them to the specialist center. For renal denervation, it is, like I said, only when the GFR is more than 40 and despite maximum antihypertensive drug therapy and they're not controlled. But again, this is still level 2. It's not, and level 2B. So, but then in certain centers where there's shared decision making, experienced centers, they are saying that you can send them to those centers if somebody is eligible. But again, the level of evidence was based on observational data, no high quality randomized controlled trials. This we've already kind of looked at. But for pregnancy, yes, if the blood pressure is more than 140 by 90, and the target should be to bring them to below 140 by 90, and do not try to bring the diastolic to below 80. That's not good. Labetalol and alpha methyl dopa still there as first choices. You can use extended release nifedipine also, up titrate the monotherapy, and then of course you don't use ACE inhibitors, ARPs, or direct renin, but you do use aspirin from 11 to 35 weeks in those who are at high risk for preeclampsia. And any severe hypertension more than 160 by 110, you should admit them and treat them with different things, including magnesium sulfate if they have preeclampsia. And for obstructive sleep apnea and other things, there are some specific ways of diagnosing them through some questionnaires and referral and documenting them through the polysomnography or sleep studies. And these are some of the other rare causes that need to be addressed accordingly. So in general, again, this is an interesting slide and which should help us change some of our practices. At least I had to change mine, because here they're saying if you have a systolic blood pressure more than 180 and diastolic more than 120 and you have acute target or damage, and so that's obviously a hypertensive emergency. These guys have to be admitted to the ICU, especially if they have aortic dissection or pheochromocytoma, and try and reduce their blood pressures to less than 140, 120 through some IV means. But if they have severe hypertension identified in the outpatient setting, they are saying no need to refer to emergency department if they don't have those end organ damage things. Just close follow-up in the outpatient, or if they're identified in the emergency department, evaluate for inpatient versus outpatient treatment, but avoid parenteral BP lowering therapy. So they are saying if somebody has severe hypertension, but they don't have the end organ damage and they have like blood pressure, let's say 180, 110 in the ER or 200 by 120 in the ER, use oral medications. Get them down to by about 25% in the first hour and then to 160 by 100 to 110 range over 24 to 48 hours. Don't have to use, they're saying don't use parenteral agents. This is something which I need to tell my ER also. And then for acute intracerebral hemorrhage, of course, you want to get your blood pressures to less than 130 by 140 within for at least about 7 days, and especially if they were presenting with 150 to 220, and you want to be careful about titrating that. But those with acute spontaneous hemorrhage who have blood pressure more than 220, don't bring them to below 130 because you extend the watershed areas of the penumbra around the hemorrhage. But when you have strokes, of course, we were all taught that don't reduce the blood pressure if it's up to 210 by 120 in the pre-thrombolytic areas. But now when you have thrombolytics available in most centers, and those who need to get thrombolytics, then we need to have the blood pressure less than 185 by 110 range. We can't leave them at the 220 by 120 range, and this is in green. So this is high level of evidence. So you should try to bring the blood pressure to that range before you give the thrombolytics and sustain it at that level. And the same thing applies to those who are undergoing endovascular treatment or stenting. for that. And they are saying that if you have, do not lower blood pressure to less than 140 within 24 to 72 hours, even after reperfusion, because that can lead to worsened outcomes. So these are some new recommendations in 2025. They're saying for resistant hypertension, whether you have hypokalemia or not, screen for hyperaldosteronism. And again, if you want to screen for a primary aldosteronism, don't worry about any antihypertensive. Only if they're on MRA, stop that, but continue all other antihypertensives. Don't waste your time taking off beta blockers and ACE inhibitors and other things, and then doing the screening for primary aldosteronism. Similarly, potassium salt substitutes can be used in patients who do not have CKD for hypertension control, weight loss in those who are overweight, DASH eating diet, reduced sodium intake, salt substitutes, exercise, anaerobic, aerobic, meditation, breathing. This is a summary of what we've already talked about. These are some of the common classes of agents, that we are all familiar with: the thiazide, the ACE, the ARBs, the calcium channel blockers, and their doses and the frequencies, the diuretics, the non-dihydropyridines. You have your potassium-sparing diuretics, the aldosterone antagonists, the beta blockers, the cardioselective ones, and the those which are cardioselective and those which are non-cardioselective, but also vasodilatory, like nebivolol, or non-cardioselective ones. And so one needs to be familiar with all this. If you are a hypertension doctor, alpha blockers in the right setting, obviously, we need to be familiar with. Some of these patches are available somewhere. They're not available in other parts of the country. Hydralazine is pretty much available. Minoxidil, not too much. I don't think we have aprocitentan. At least I don't know if it is there. Various doses are mentioned. And similarly, when you have hypertensive emergencies, then nicardipine, clobidipine, sodium nitroprusside, nitroglycerine, all these things, some of these things are available. Some of these things may or may not be available in different parts of the country, but we do have labetalol and, of course, phentolamine. If you don't have that, you use some other alpha blockers and pheochromocytoma and the like. For aortic dissection, esmolol and labetalol is recommended to decrease blood pressure to less than 120. Pulmonary edema, of course, nitroglycerin, nitroprusside, clobidipine if it's available. And these are some of the other things, whether the eclampsia is still hydralazine, labetalol, nicardipine, nifedipine. Perioperative hypertension, if you have more than 160/90, then you can still use these medications. And acute intracranial hemorrhage, these are the different types, also acute ischemic stroke. So these strategies, and also for those with, of course, patients who have CKD, it's important because these are usually non-dippers also, and diabetics and non-diabetics both need to be treated with CKD, targeting less than, when they're more than 140/90 to less than 130/80. But if you go to below 120/70, it's not recommended. It may be harmful. So we need to stop, between 120 and 130 and 70 to 80. We don't want to go below this in our overzealousness to delay progression. We may worsen progression. And of course, SGLT2 inhibitors in the right setting, finerenone in the right setting for CKD and diabetics with GFR over 25. All these things are there. And they're saying that if you need to use some of these mineralone, the RAS blockers or MRA, then you may want to maintain your potassium through potassium binders to below 5.5 and can use them as necessary. In obesity, loss of weight, or thiazide type diuretics may be a problem here, thiazide type diuretics or beta blockers, because of the hypertriglyceridemia and other effects. But of course, they are saying that do not use these things like Ozempic and other similar drugs for BP control in those with obesity, and do not refer patients who are obese for bariatric surgery for blood pressure control. So this is important. Similarly, BP should be monitored in all these people. They are non-dippers mostly, the diabetics, SGLT2 inhibitors, finerenone. This is just a recap of most of those recommendations. And for surgical things, do not stop beta blockers in the perioperative period. Do not delay your surgery if your preoperative blood pressure is less than 180 by 110 and it's a non-cardiac surgery. You don't have to postpone it. The anesthesiologist does not have to postpone it. Do not abruptly stop clonidine or beta blockers, as we understand. So this is another opportunity for screening people. For children, if they have blood pressure more than 95th percentile, between 0 to 15, or more than 140/90 over 16, then again, that's hypertension. And then screen them for secondary causes, other causes earlier on. I think that's also important. The new one, the baxdrostat, that is now being touted as the wonder drug in uncontrolled and resistant hypertension. It's an aldosterone synthase inhibitor, and at least the clinical trial, I think maybe in one of our journal clubs we will use this. I think it was published in New England Journal of Medicine. So we probably should do this as a journal club. So they are claiming that among patients with uncontrolled or resistant hypertension, the addition of baxdrostat resulted in a significantly lower seated systolic blood pressure at 12 weeks than placebo. Of course, whether it will translate into long-term improvement in outcomes, that remains to be seen. So in general, when we diagnose it, initiate the phase in the first 3 months, some lifestyle modifications, screening tests, just try to get the blood pressure controlled within 3 months, do a short-term follow-up, do a risk assessment and long-term follow-up. That's the way that most of us would be managing patients, keep them below 130/80. If after 3 to 6 months of lifestyle changes, they still exceed that. And then particularly, we need to understand that controlling high blood pressure is also important to prevent dementia. And it's important for CKD, for heart disease, and in the right settings, the right prophylaxis. So as take-home message, high blood pressure obviously is important in as a determinant of coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, CKD, and all-cause mortality. And for all of these patients, we need to approach it through a lifestyle change in terms of weight management and healthy dietary habits and exercise, and decreasing salt and decreasing smoking and decreasing alcohol or increasing potassium, and then going on to the medication therapy. And we obviously need to prevent all these outcomes with effective control. It does not necessarily need to remain a silent killer. I think in Pakistan and places like that, if we just simply take care of our diabetes and heart and high blood pressure in our population, we can make a significant difference to the majority of the population living below poverty lines in this country. So I will end by doing a quick mini quiz, and here you can participate. And then if there any time for questions, so we'll try and end in about 5-10 minutes, inshallah. So what is the target systolic blood pressure for adults receiving blood pressure medications according to the 2024 European Society of Cardiology guidelines?
Less than 130.
Okay. Yeah, so 120, 120 to 129, great. According to the ESH 223 guidelines, what is recommended for patients with suspected hypertension? Only use office blood pressure or use out of office blood pressure monitoring for diagnosis?
Out of office blood pressure.
This is actually office blood pressure. So they are saying that, yeah, out of office to confirm your white coat and mask, but when you want to confirm a diagnosis, then they're saying do the office blood pressure once. That's where you can assess your hypertension-mediated organ damage and other things. What is the definition of hypertension according to AHA 2025 guidelines?
More than 130/80.
So more than 130/80. According to the ESH 2023 guidelines, what is the recommended initial treatment for patients with stage 1 hypertension?
So lifestyle medication.
Okay, so according to AHA ACC 2025, what is the recommended approach for patients with resistant hypertension?
Investigate for secondary causes of hypertension.
Excellent. According to ECC 2024, what is the recommended frequency for blood pressure monitoring in patients with hypertension?
Every 3 to 6 months.
Great. According to ESA 2023, what is the recommended approach for patients with masked hypertension?
Use office blood pressure measurements along for diagnosis. No, sir. Out of office blood pressure monitoring.
Good. What is the recommended treatment approach for patients with hypertension and diabetes according to the ECC 2024 guidelines?
A, sir. Go for A.
Okay. According to AHA-ACC, what is the recommended approach for patients with white coat hypertension?
Out of office blood pressure monitoring for diagnosis.
Good. According to ESA 2023, what is the recommended approach for patients with hypertension and cardiovascular disease?
Sir, go for A.
Comprehensive cardiovascular risk assessment. What is the primary goal of hypertension treatment according to AHA-ACC guidelines?
B.
Yes, so reduce cardiovascular risk. What lifestyle modification is recommended for patients with hypertension according to ECC 2024?
Increase potassium intake.
What is the recommended treatment approach for patients with hypertension and CKD according to ESH 2023 guidelines?
A.
What is the definition of resistant hypertension according to ACC 2025 guidelines?
Blood pressure more than 140/90 despite optimal doses of 300. B. Oh.
Blood pressure more than 130/80, ये लोग कहते हैं ACC वाले, despite optimal use of 3 antihypertensives including a diuretics. What is the treatment threshold for initiating antihypertensive medication according to ESH 2023 guidelines?
It's more than 140/90.
How do the AHA-ACC guidelines recommend assessing cardiovascular risk in patients with hypertension?
So prevent this.
Okay. What is the definition of hypertension in adolescents according to AHA guidelines?
Blood pressure of more than 120/80.
Adolescents में 140/90 है और
Sorry.
ये है blood pressure greater than the 95th percentile for age, sex and height. Yeah. What is the recommended screening test for primary ALDO?
ARR.
What is the recommended medication for acute severe hypertension in pregnancy?
Labetalol.
What is the characteristic biochemical finding in primary ALDO?
ALDO low renin.
Okay, so that is it. And today we have kind of gone through this this particular session, and thank you for staying till the end. Sorry for going over the time limit. This is being recorded, and I will send it to all 5 of you, so that those who missed the first portion can then look, go through that. So thank you very much. Any comments, any questions, please?
Thank you very much.
Learned a lot.
Sorry. I could not.
Can you hear me?
Ji, please.
So there's one comment rather than a question,
Yeah.
Like comparing different guidelines, like UK NICE guidelines, European Association, American Heart Association. I mean, they all think that optimal blood pressure or normal blood pressure, in inverted commas, is less than 120. But do you think by decreasing the threshold in American guidelines to actually between 130 to 140, they still think it's a stage 1 hypertension, and starting antihypertensive medication, it's actually sort of overdiagnosing hypertension? Or you think it is actually, I'm sure they have got some trials to actually favor this. But I don't know. I just think that maybe by just lowering the threshold, they are diagnosing a lot of people um, hypertensive. And there is the discrepancy between when to start the treatment between the guidelines. Because I know lifestyle intervention is a sort of a common thing in a pathway, but realistically speaking, um, they just go on to the pharmaceutical therapy, all these stage one hypertension as proposed by the American Heart Association. And also they were saying that you need to treat this blood pressure as early as possible, even when you classify it as a pre-hypertension as per UK guidelines. They just treating it as a elevated or a stage one hypertension, and just being a devil's advocate, that means that there is a lot of people who are going to be prescribed antihypertensive medications. There is a lot of going to be benefits to the pharmaceutical companies. I'm not sure that whether there is a very clear evidence of sort of a risk reduction in terms of cardiovascular mortality in patients who doesn't have other risk factors in terms of diabetes or cardiovascular family history. And also, I want to know what risk calculator they have used when they calculate the cardiovascular risk scoring system. Was it a Q3 risk score or a risk-free Q score, or there is something else they've used?
Yeah, I mean, like, so now they are just using the prevent.
But okay.
Yeah,
Okay.
and previously they were looking at the score, OP, and whatever, the previous risk scores, and which the ESH was also using. But now it's all gone on to prevent, which is probably only validated in the US population or North American population. And I think all your comments are very, very valid. And yet there is, that fear that if we fail to address hypertension with all the seriousness, then a lot of people, as you know, in our culture, they take medications when they feel they have hypertension, when they feel they have headache, when they feel they are dizzy, when they feel they have blood pressure, and they don't actually measure it and they don't actually adhere to things. So I think when you're looking at all the complexity, it is a catch 22. If you label somebody early, if they take it seriously and at least some of them start taking their lifestyle and medication seriously, maybe they will prevent cardiovascular and renal and stroke related outcomes. And yes, the pharmaceutical companies definitely will get richer, yeah, because of the lowering threshold. I can obviously see that happening, and we have to be very cautious with what is being promoted, what are the risk benefit ratios, and it's always a question of the number needed to treat and number needed to harm. And I think that will decide what thresholds people should be using. But I think as a consensus, we already knew that we want to get blood pressures down below 130 by 80 for most of the cardiovascular and renal and cerebrovascular outcomes. And regardless of whether you call something stage one or whether you call something a high normal hypertension, they all are recommending that when you have the additional risk factors, take it seriously. And I think if the additional risk factors are not there, even the American guidelines are saying, okay, you can take it casually for 3 to 6 months if your blood pressure is about 140/90. But if after 6 months it stays over 140 by 90, bring it down. And on the other hand, the Europeans might say, oh, you don't even have hypertension till you are 140/90. So I think it is a little bit of that incremental risk that we know occurs with other risk factors that eventually, drove them towards this. There are some levels of evidence they're quoting in green and yellow and red, and I think we just have to fit it to our individual patients and practices. But I hear you. I think there's a lot of skepticism in terms of why the pressures have been lowered down and all that. And that the same can be said about diabetes when the diabetic fasting thresholds and other things were brought down. Again, whether it is early treatment will prevent complications, or it's going to be lead time or lag time diagnosis delay. I think that's the question for the future to answer. But yeah, those questions are very well appreciated, and comments are very appreciated, much appreciated. Thank you so much. And Dr. Hanif, any comment?
Yes, sir. I have one query as well. There are a lot of discrepancies between the guidelines. Like in our clinical setting, we do abide by. We see a lot of GN patients over here, and we mainly abide by the guidelines which are recommended by the KDIGO, which implies that anyone which has kidney disease, particularly proteinuria, so we target the blood pressure of less than 120 of systolic, but we don't have the regional guidelines over here. So we face the challenges in European societies. I don't have the exposure with them, but I assume that they follow the European guidelines, while in America they will be following these SEC guidelines.
Yeah.
But in here we don't have regional guidelines. So is there
Yeah.
any
Yeah.
work?
The General Suhail Sabir's group came together in the Cochrane, Pakistan, and they did some adaptation of the KDIGO guidelines for Pakistani population. So I think they published the first set of those adaptations. They're not originals; they're just adaptations of the guidelines. But as far as that 120 cutoff is concerned, now there's data coming out that we should not be reducing blood pressures below 120 by 70 in any category of chronic kidney disease patients or GNs because of the associated poor outcomes in terms of renal decline in GFR. So I think one has to be we were going to that other extreme because of the sprint trial and the other trial, I forget the name, and so 140 and 120 were the targets, but now they are suggesting that at least don't go below 120 in any circumstances in chronic kidney disease or in GNs. So I think that's some newer data which came out from some of these recent studies. We can do a journal club on that as well, and that is so we keep learning from our experiences, and our job is to make sure that high blood pressure is taken as seriously as a nephrologist as it should be by a primary care physician or a cardiologist. And we have a lot of business in hypertension to because of the prevalence of chronic kidney disease in the country and the way it is increasing globally, 1 in 8 patients and all that. So we need to take care of hypertension as aggressively and also become advocates as much as the cardiologists or even more when it comes to our areas of interest. And a lot of secondary hypertension is all renovascular and renoatherosclerotic, as we understand. So I think that's why my desire is that the nephrology community should start taking more and more ownership of the of hypertension as a subspecialty of its own, because it directly affects outcomes in renal disease as it does in cardiovascular and cerebrovascular. So with that, I will end. Thank you so much, and I will send you all the recording, inshallah. And thank you for your support always. Thank you. Assalamu alaikum.
It was very good. Thank you. Bye bye.
Thank you. Bye-bye. Assalamu alaikum.